Yeah, back again. And it's my pleasure to introduce Professor Kenneth Connor, who is a clinical psychologist and professor of emergency medicine and psychiatry at the University of Rochester Medical Center, where he also serves as co-director of the Center for Suicide Prevention, for study and prevention of suicide. And his research focuses on the links between alcohol and other drug use and suicidal behavior, high-risk clinical approaches, and emergency care for suicidal patients. So in this presentation, Kenneth Connor will speak about warning signs of suicide, and it's based on his studies. So the floor is yours.
Excellent. Well, it's spectacular to be here, and I'm very happy to have been invited, and it's nice to be with you. Sorry I couldn't be with you in person. I've been sick this week, so that explains my voice. And we'll get started. Are you able to see that? Okay, I'm going to talk to you about acute risk factors for suicidal behavior using a data set of patients we interviewed in the hospital after attempted suicide. I'd like to acknowledge my collaborators in this work, Dr. Courtney Baggy at the University of Michigan and Dr. Jacqueline Kearns in Boston, including the VA hospital there, and a grant to Dr. Baggy and I that supported this work from NIH. Warning signs are acute risk factors, and there's little research on warning signs because of the difficulty of studying the minutes and hours preceding suicide attempt or suicide. Essentially, Dr. Baggy's work and my collaboration with her shows that people who have attempted suicide are very different on the day of the attempt than they were on even the day before. There are changes in emotions, thoughts, behaviors, and social experiences that are unique to the day of a suicidal act. And therefore, in order to understand acute risk, it is essential to examine the day of suicidal behavior. There are different conceptual models of acute risk. These include the suicide crisis syndrome, or SCS. This is a syndrome that was developed by Igor Galinker and his colleagues at Mount Sinai Hospital. And the suicide crisis syndrome has a diagnostic style approach. So it's essentially, according to the SCS, it's essentially a diagnosis like we would make other mental health diagnoses. The core symptom is entrapment, or the inability to escape. They've also called this frantic hopelessness. And additional criteria include affective disturbance. This is a broad range of acute emotional difficulties, including emotional pain, rapid spikes of negative emotions, extreme anxiety, and acute anhedonia. They also posit that acute risk involves loss of cognitive control. This is also a broad set of experiences, including rumination, cognitive flooding or overload, just an overwhelming number of thoughts, racing through one's head, or an inability to suppress or deviate from a negative thought pattern. They also posit that arousal is part of this syndrome. That would be agitation, hypervigilance, irritability, insomnia, and then social withdrawal. So backing away from social interactions or responsibilities. Here's some, so the data set that I will present are from narrative interviews with patients who have attempted suicide and have been hospitalized, and we interview them about the day of their attempt and what their experience was. And these are some quotes from our database that map to the SCS criteria. Entrapment or hopelessness. Why keep going on in life with all these thoughts? Affective disturbance. I just broke down. I was sitting at the bus crying, on the bus crying. So breaking out in tears, crying is commonly described by patients who have attempted suicide. Cognitive disturbance. I want to stop caring. I want to stop worrying. And like I said, I tried to shut everything up in my mind. So the person just feels like they can't stop this negative pattern of thought. They can't shut it down. Hyperarousal. I was like so angry. I just get agitated so quick. Social withdrawal. I didn't go into work. I didn't call in sick or anything, like I just was in the bed the entire day. Another hypothesized framework for acute risk is called the acute suicidal affective disturbance, or ASAD. This syndrome was posited by Thomas Joyner and his colleagues. The core syndrome is a drastic increase in suicidal intent. And interestingly, you might have noticed with the other formulation, the suicide crisis syndrome, there were no suicide-specific indicators of risk. And the reason for that is that Glinker believes that patients will withhold that information. Therefore, it's critical to identify other indications of acute risk. This formulation takes a quite different approach. They view a drastic increase in suicidal intent shortly prior to suicidal behavior as the core symptom, as being essential to understand if a person is at acute risk. And then other criteria include social alienation or self-alienation. Social alienation includes perceiving that one does not have supportive relationships or reciprocal relationships, perception that nobody cares or understands, or disgust with others. Self-alienation includes self-disgust, self-hatred, self-blame, shame. It also includes humiliation. Another criteria is feeling hopeless about one's experience, about one's suicidal intent and experience of self-alienation or social alienation. And then the final criteria is over-arousal, which is similar to the idea with the SCS, agitation, irritability, etc. Here are some sample quotes that from our database that map to ASAD criteria. Increased suicide intent. Once I was pretty decided on suicide, I didn't want ways to cope. I wanted to just end it so. So the person had made a firm decision to try to kill themselves. social alienation or self-alienation, but nobody's going to care if I'm here or not. Example of social alienation. Nobody wants to be with somebody that's ugly on the inside. Example of self-alienation. Hopelessness or entrapment. Why keep going on in life with all these thoughts? Over-arousal. Excuse the spelling error. I just got agitated so quick. In my view, there are some limitations of the ASAD and the SES, both of which use diagnostic style approaches. Number one, they assume relative homogeneity in acute risk. So the SES says one must have all 5 of these criteria. The ASAD says that one must meet all 4 of these criteria to be considered at acute risk. And that's, in my experience, acute risk is more heterogeneous than that. And it's difficult to have people meet all criteria simultaneously, even though they may be at acute risk. There are also potential consequences to using a suicide-related diagnosis. For example, if it's in somebody's medical record, concerns that could be stigmatizing to them when they come back for care, or have implications for their insurance. Insurance is a big deal in the United States. I'm not sure about the situation in Lithuania. And then these formulations, the ASAD and SES, there's limited research pertaining to imminent risk per se. When I say that, I mean little of the data on those syndromes has to do with the day of a suicidal act. So this very acute risk period that we're focused on today. My colleagues and I have developed another model of risk. We call it warning signs of acute risk in narratives, or WARN. Narratives are simply patient stories of their attempt. So our model hypothesizes that acute risk states are produced by a broad set of cognitive, behavioral, emotional, social, and somatic variables, which we conceptualize as drivers. And Warren further posits that drivers lead to a narrow set of highly potent warning signs with direct suicide content that warrant prioritization in acute risk assessments. So the first statement, in my view, speaks to the heterogeneity of acute risk. There are a large number of thoughts, behaviors, emotions, social experiences, and somatic experiences that could precede or occur during acute risk. So there's heterogeneity. But the second statement says that when there's a perfect storm of these experiences that can give rise to acute risk and effectively give rise to experiencing highly potent warning signs with direct suicide content. And I'll explain what I mean by that. So here's the model. It's a simple model. These broad drivers, cognitive, behavioral, etc., lead to acute suicidality, which in turn creates the conditions for suicidal behavior. Here's an example of drivers in the emotional category. So there's a lot of different drivers, potential emotional drivers of acute suicidality. They include dramatic changes in mood, such as breaking down in tears, rage, anger, hostility, seeking revenge, anxiety, related experiences. Emotional pain, which is a broad category, sadness, emptiness, hurt, misery. Self-alienation, we've already talked about. Acute anhedonia, emotional depletion or emotional exhaustion, and emotional numbness. It's interesting, in our database, we see patients talking about, I'm just tired, I just can't do this anymore, which is this experience of being emotionally depleted. Okay, here are examples of warning signs with direct suicide content. They include resolving to attempt suicide in the near future. This is basically the same variable as posited in the ASAD, that notion of acute increase in suicide intent. This is really the same thing. So a person being resolved to attempt suicide now or in the near future. Another warning sign with direct suicide content is self-persuasion to attempt suicide. I will come back to that because it's a very interesting issue that we identified in our data set. Another is weighing the decision whether to attempt suicide. So this is active ambivalence. The person is having an argument with themselves whether or not to go through with suicide. Taking steps to prevent interruption of suicide attempt. For example, arranging to be alone, locking the door, etc. Making preparations of personal affairs. These are things like leaving a note, arranging for someone to take care of one's pets, other actions in anticipation of death. Suicidal communication or threat. So it might be someone talking to someone else about feeling like they want to hurt themselves, or a less direct statement, but nonetheless it's clear they're talking about suicide. Coming upon a method of suicide while vulnerable. This is an interesting phenomena that we identified in our data set. For example, one patient I interviewed was intoxicated. He was acutely depressed. He was experiencing a lot of the self-alienation that I mentioned. Essentially, he's disgusted with himself. He hates himself, including because he's gone back to drinking, and he's ashamed of that. And then he opened his drawer to get his insulin medication. And in that moment, when he was vulnerable, he decided to take a massive overdose of insulin, and he injected it into his belly. So this is a person who wasn't thinking of suicide prior to opening the drawer, but he was very vulnerable. And then he came upon a method and quickly took an action. Last on this list is settling on a plan or refining a plan, or sorting through method options, methods meaning different ways of hurting oneself, trying to kill oneself. So what is our qualitative research on warning signs, and how did we develop this WARN framework? Well, it's 3 years ago now. We published, Jackie Kearns and I, we published a research paper where we analyzed narrative stories of the day of attempted suicide, and we tried to make sense of those stories, and we published that in General Hospital Psychiatry. And then I'll tell you about data from an ongoing study that we've analyzed. So I have a study funded by the National Institute of Health, and Dr. Courtney Baggy at the University of Michigan and I are the PIs. For this study, we recruit patients who have been hospitalized, and we're particularly interested in learning about the day of their suicide attempt and the day before. So we do an intense inquiry into their experiences on the day of the attempt and the day before, after they've been in the hospital for a couple of days and are able to speak with us. Our study uses qualitative and quantitative methods, and today I'm going to talk about qualitative data, in particular qualitative analysis of 45 patients' stories of the day of their attempt. The patients were about 60%, or 60% of them were ages 18 to 35, so a somewhat younger population. 71% were white, and then you could see their other racial backgrounds there. Almost exactly half were female. 11% were Hispanic. 36%, about a third, had a college degree. And very typical of a suicide attempt population, the most common method of suicide attempt was by self-poisoning. They tried to take an overdose. And 58% had a prior history of attempted suicide, and the other 42%, this was their first suicide attempt. Our methods. So we invite patients to tell the story of their attempt, focusing on the day it occurred. We audio record their stories, and then we transcribe them. We generate these written transcripts. We go through the stories and identify the sections of them where the patients are talking about the day they attempted suicide. And then we proceed to code them using a detailed coding manual. Specifically, we're detailing the transcripts for warning signs. And most of the coding I do myself, so I'm quite familiar with the transcripts. And then Dr. Jackie Kearns does the rest of the coding. We code the kinds of behaviors and emotions and thoughts that map to our Warren model, as well as that map to other models, including the SCS and the ASAD. These include cognitions, behaviors, emotions, social experiences, arousal or somatic variables, and warning signs with direct suicide content. And we use an analytic technique called directed qualitative content analysis. So what is our narrative interview? The first thing we do, we turn on the tape recorder and we ask the person to tell me the story of your suicide attempt. And often they'll say, I don't know where to start, or what do you want me to say? And we will say to them, it's your story, start wherever you like. After they've told us the story or some of the story, we then ask them to talk more about the day of the attempt itself. Some patients will immediately talk about that day, but others will talk about historical experiences. They might talk about trauma as a child, or divorce, or some other experience that made them vulnerable. So here we're asking them to focus on the day of the attempt. Please tell me more about that day. And then we ask some follow-up questions. Where were you and who were you with? What were you doing? What were your thoughts and emotions? And what bodily sensations were you having? In terms of some of the results we're getting, again, we're quite interested in results that may map to our conceptual model, WARN. So in terms of cognitive drivers, the most common cognitive drivers we're seeing are hopelessness or perceived entrapment and cognitive disturbance. Interestingly, these are also variables that are posited to be very important to acute risk by the suicide crisis syndrome, the SCS. The most common behaviors we're seeing are alcohol use on the day of the attempt, communicating distress. So communicating distress is not the same as communicating suicidality. This is communicating that I'm feeling sad, I'm upset, I want to talk to you, etc. And sleep changes and difficulties is also occurs about 22% of the time. Emotional difficulties, emotional pain. Again, this is a broad category of experiences. Dramatic changes in mood, such as breaking down crying or sudden increases in intense emotion and anxiety. Social experiences, perceiving loneliness or that the person doesn't have social support or relationships is common. And then negative interpersonal event or exchange. These are things like having a fight, having a disruptive argument with somebody they care about, oftentimes a relationship partner. And then arousal or somatic experiences, agitation and irritability they may experience. And then a slowing or quieting of behavior. This is interesting. Some patients, about a quarter, will describe that they're talking more slowly, they were moving more slowly, they didn't have any facial expression, they were sort of shutting down. So the slowing or quieting of behavior, some people describe. Example. So here's an example of cognitive disturbance. My mind was racing. Physically, my brain was probably racing. Thoughts that just, were uncontrolled. Automatic thoughts that come into your head. And so some of that type of racing thoughts come in, and then thoughts about right now, like I just seem to be almost incapable of taking care of certain things. So he's talking about racing thoughts. This is a male who is 63. And even as he's describing it, it's not a very grammatically good sentence. You can see, even in his description, perhaps some elements of cognitive disturbance that might be carrying over. Dramatic change in mood. As soon as I got in my house, I just fell on my knees wailing meaning crying. I haven't cried like that before. This was a male who was 25. Emotional pain, an example. The feeling was really dark, really sad, a lot of hurt. It's a woman who was 39. Anxiety, I felt really anxious and nervous immediately, just like a strike on me. 24-year-old woman. Loneliness, I had no family and no support. A woman who was 47. So what about warning signs with direct suicide content? These are These are quite common. The most common is resolving to attempt suicide in the near future. That is making this being determined to make a suicide attempt that day. 56%. And then some other experiences, making preparations to attempt suicide. I'll give you an example of that. Settling on a plan. Self-persuasion to attempt suicide. I'll give examples of that. And active ambivalence. Resolving to attempt suicide in the near future. If all three don't answer, then I'm just going to do it. I'm going to do it. That's my sign. So this was a woman who was trying to get a hold of people to talk about her suicidality. I don't remember who they were. Maybe one was a therapist. And she was saying, if they don't pick up the phone, then I'm going to try to kill myself. Making preparations to attempt suicide. I opened the kitchen drawer and grabbed the knife. I grabbed the blade sharpener and I started sharpening the blade. I got the detergent or whatever, I washed it off. I wanted it to be clean. A male, 25-year-old man. Settling on a plan. At that moment, that kind of pushed me over the edge, and I just decided to overdose on painkillers. So he, or as a woman, a young woman, she made a more or less spontaneous decision to try to overdose on painkillers, probably opioids. So active ambivalence, weighing the decision. My parents, it was like either way, either whether I had left or whether I had attempted suicide, I knew I was going to hurt them either way. No matter the decision I made, I was going to hurt them. So the person is trying to decide whether to, I'm not sure what they mean by left. I don't remember this case, but perhaps leave the household or attempt suicide, and they're agonizing about what decision to make. This phenomena of self-persuasion to attempt suicide, when we began this work, we did not think about this phenomena, and as far as I can tell, it's really not described in the literature in any detail, but it was something that we saw repeatedly in our narrative stories, and we gave it this label self-persuasion to attempt suicide. Here's a definition. Building themselves up to attempt suicide. For example, by reassuring themselves that suicide will not be devastating to others, it will not be painful, it will be similar to their everyday experience, like taking a nap, or that things will be taken care of despite their suicide. For example, my pets will be cared for. So the person is reassuring themselves and talking themselves into trying to kill themselves. Examples. This is a woman who was very depressed. She had chronic pain. I remember interviewing her, and one of the things that she said to herself was, and I have to make myself do it because I can't keep backing out. I just have to do it. People trying to think of it like going to sleep is common with self-persuasion. I'm just going to take a nap in my car. Like I'm not even going to be awake when I die. This next quote is from the first person I interviewed when I began doing this work. It was an 83-year-old woman who tried to kill herself with self-poisoning. And she said to herself, either you're going to do it or you're not going to do it. You're not going to sit here and dwell on it. That's not going to make you do it. I was on my last day. This is a little bit complicated, but I'll try to explain it briefly. So we found that resolving to attempt suicide in the near future was the most common warning sign with direct suicide content that our patients experienced. And so in those situations where a person had that warning sign, we wanted to look at what were the drivers that preceded it. So in the brackets are percentages. So of the people who resolved to attempt suicide in the near future, 48% of them were experiencing hopelessness. 48% of them were experiencing cognitive disturbance. 32% of them had used alcohol or drugs that day. Non-medicine drugs, drugs of abuse. 24% had communicated distress. 20% were having sleep difficulties. 56% were experiencing emotional pain. 52% had dramatic changes in mood. 52% were experiencing anxiety. 48% were perceiving loneliness, or they didn't have any supportive relationships. 36% had a negative interpersonal exchange or event, so they were arguing or fighting with somebody important to them. 36% of them had some marked physical discomfort. And by this, I mean not pain, but some other marked physical discomfort. They might feel a heaviness in their chest, for example. And then 28% were experiencing agitation or irritability. So you can see why we came to the Warren model. We have this common experience of resolving to attempt suicide in the near future on the day of an attempt. But we have these a large number of different thoughts, behaviors, emotions, social experiences, and somatic experiences that that accompany that experience, and according to our model, that are driving that experience. So again, Warren hypothesizes that acute risk states are produced by a broad set of cognitive, behavioral, emotional, social, and somatic variables conceptualized as drivers. We further posit that the drivers lead to a narrow set of highly potent warning signs with direct suicide content that warrant prioritization and acute risk assessments. A couple cautions. One is that even warning signs with direct suicide content do not indicate suicidal behavior will occur. The low incidence rates of suicide attempt and suicide remain a barrier to making accurate predictions of risk. So therefore, in an emergency situation, somebody could be showing many acute risk factors according to Warren, or according to the ASAD, or according to the SCS, but they still don't go on to attempt suicide. And this is the low incidence rate of these behaviors make prediction very difficult. Another caution is some patients will withhold warning signs with direct suicide content, and that complicates assessment. And as I mentioned, in the SCS, they don't even feature those warning signs because they're concerned about patients not sharing them with providers, for example, a provider in the emergency department. We did, as I said, we did look at um, how these, we did look at our transcripts and our codes and the extent to which they mapped onto these other formulations, including the SCS and the ASAD. And those formulations were quite successful insofar as a number of the experiences contained in the stories were seen. Um, uh, let me stop there. We have 15 minutes left, so I have some other things I could mention, but let's just go on to questions and discussion.
Okay, thank you so much for the presentation. And really, I have one comment and one question from the participants. So I will start with the comment that qualitative research allows us to understand people with suicidal intentions, their position and situation in a very real way. Thank you very much. It was an excellent presentation. So nice to hear that. The question, very specific one, when providing social services to intoxicated individuals, how can we detect suicidal behavior? Are there any specific questions we should ask?
A great question. But could you say what you mean by when providing social services? What do you mean by that?
That's a question from the participant, so I cannot know what exactly,
Okay.
but I would imagine for example, that could be a question from a social worker. For example, social worker visiting a family or individual for some reason, and it's an intoxicated person, and yeah. So that's how I would understand this question.
Okay. Good. Excellent. Um, So this is an area of expertise of mine. It's an area of interest is the role of alcohol in suicide. So I'm very pleased that you brought that up. Alcohol intoxication is a very potent acute risk factor for suicide attempt and suicide. And there are some pretty strong data that a person who's intoxicated estimates of around 30 times greater risk for suicide attempt while intoxicated than compared to a person in the same situation who's not intoxicated. So intoxication is a potent risk factor. The setting that I'm familiar with this issue is the emergency department or somebody calling into a crisis line. In terms of an emergency department, it's an easier situation because really the standard of care, if you're concerned about the person being at risk, the standard of care would be to wait for their blood alcohol level to drop and then to reevaluate them, because it's difficult to get a decent assessment with an intoxicated person. And also, it's very difficult to feel good about allowing somebody who's intoxicated and you're worried about their risk, feel good about them leaving the emergency department until they're sober. On a crisis line, for example, a hotline, somebody calling, that's a more difficult situation because you don't have that kind of control over the person. And I think the most important thing to do is to realize that intoxication is a very potent risk factor and that it could indicate that some kind of intervention is needed, such as considering at least sending people to the home as a welfare check. At the same time, that can be a very scary experience for somebody to have people come to the home as a welfare check. In the United States, often that is the police, and that can be very frightening to people, or or agitate them, etc. And the police don't really want to deal with that often either. And so it's a difficult situation to take a step like that. I'll also say that most people who are intoxicated aren't at any risk of suicide. You know, we go to a sporting event and people are drinking, or we go to a party, people are drinking, or what have you. We typically don't concern ourselves with risk in those contexts. So usually you would have some hint or inclination that the person is at risk, and not merely trust the fact they're intoxicated as an indication. You know, they've been isolating themselves, they've been saying things that are of concern, etc., before you would begin to think about that.
Okay, so following up on this question and your answer as well, I've heard many times from clinicians like working, for example, in a mental health hospital that they would receive, they would care as a professionals for a person who attempted suicide while intoxicated. And they find extremely difficult this work with these patients as a psychologist, as the psychotherapist, for several reasons. One of the reasons that after the person is sober, they would deny the seriousness of attempt, that it's not, that it was something stupid, something non-intentional, and so on. And sometimes, and the other difficulty that they would be not very much motivated on, working psychologically through their difficulties. Is it something you are familiar with, or would you have some insights for that kind of problems?
Yeah, a couple comments. One is, that if the person has a severe alcohol problem, they may not remember. They may have blacked out and may not remember um, their suicide attempt or their emotional state when they were suicidal and intoxicated. So their report, it could be that they just don't want to cooperate, and they just don't, they just want to get out of there and go home. It could be it, but there also could be an insight issue, and the person could genuinely not be aware of how they were behaving and what they were experiencing when they were drunk. And that, that commonly occurs. The issue of motivation, that's an important one. I mean, if the person doesn't have any interest in addressing their drinking, then that creates a major challenge, because the drinking is so important to understanding their acute risk. There are techniques to increase motivation. For example, motivational interviewing is a very strongly evidence-based intervention technique. And in fact, I have a colleague named Peter Britton here in the United States who is doing a study of the use of motivational interviewing with patients with acute suicidality, and he's getting some very nice results. And then oftentimes family members can be even more motivated than the patient themselves. So it can be very useful to have an interaction with somebody close to the patient, their daughter, their wife, to see if they can be helpful in making sure they get to an appointment or being a part of their treatment, because the person with alcoholism may really value those relationships and really want to maintain those, and that could be a motivating factor for them as well. I would also like to say that there tends to be a lot of stigma toward patients with suicidality, and then the stigma is increased quite substantially if the person also has an alcohol problem. So this tends to be a highly stigmatized population. So sometimes providers don't go into the interaction with the best mindset either. They might have experiences from prior patients or sort of ideas about what this patient will be like before they begin to talk with them. So always be on guard about, well, what are my preconceived ideas about this patient? Because sometimes they won't be true, and you don't want to be biased against the patient before you've even begun to try to work with them.
Okay, thank you. And one more question from the participants. Are there any factors that point us to the predisposition of the person to repeat the attempt after the discharge from inpatient care?
Could you repeat the question?
Yeah, no problem. Are there any factors that point us to the predisposition of the person to repeat the attempt after the discharge from inpatient care?
Yeah, there are predictors of repetition. They include prior history of attempt. So people with multiple attempt histories are more likely. Younger age is associated with repeat attempt. And there are some diagnoses or that are predictive, such as borderline personality disorder. That would be a predictor of repetition of attempt. And then to some extent, the person's attitude toward the attempt is also important. So people who are disappointed they didn't die, who didn't want to be saved, who are maybe angry for people who rescued them or what have you, that can be a very bad prognostic sign. And typically you would want to try to work with that person as much as you can so that they change their view of the attempt and having survived. And you do see during inpatient hospitalizations, people come around to a different view eventually with therapy and with intervention. Yeah.
Thank you. And I think we can go for the one last question. That there's also one question. It's a little bit similar to the questions before, but maybe a little bit some different nuance. Thank you for such vital topic, for addressing such a vital topic. Question: if you would, address the severity of clients' addiction and consequences of such on their deteriorating mental and physical health?
Well, yeah, I mean, there's no substitute for providing treatment of alcoholism or addiction, because certainly when people are in the active addiction or active alcoholism, they are at increased risk for a number of reasons, including the negative mood states that substance use induces, plus during withdrawal states. And then substance use creates such difficulties in their lives with interpersonal relationships or with becoming homeless or being unemployed, etc. So treatment of addiction is essential. And it becomes more complicated with a suicidal patient, but certainly you never want to forget about the addiction itself, which is feeding risk and is vital to address.
Okay, thank you. And it's interesting, you know, the presentation was mostly about acute warning signs, but including those that are connecting to alcohol. And most of the questions were related to alcohol, which is interesting because just after the short break, after 15 minutes, we will have a presentation by representatives from Alcoholic Anonymous. So we will follow up this topic then.
Oh, excellent. Yeah, and if anybody wants to contact me, I put my email in the on the screen before, but because I do alcohol suicide research. So if anybody wants to email me, that'd be great. Yep.
Okay. Thank you so much for your time and for your presentation and the work you are doing. Thank you so much.
Thank you for inviting me. Bye.
Dabar 15 minučių pertraukėlė iki 16:15.
Now we will have a 15 minutes break until 16:15.